At a convention of the Medical Committee for Human Rights held in Chicago in 1966, the Reverend Martin Luther King declared, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." Yet the U.S., with the most highly trained healthcare professionals in many of the leading medical facilities in the world, still stands alone among industrialized nations in not having universal healthcare, and fails to consider healthcare as a basic human right, even though it's a signatory to the Universal Declaration of Human Rights, adopted by the United Nations, which states everyone has the right to a standard of living adequate for the health and well-being of himself and his family, including food, clothing, housing, and medical care. Welcome to Over Here, Over There, a global conversation about how we see ourselves and how others see us. I'm your host, Dan Harris, and for the next 45 minutes or so, we'll be asking our panel of guests from Germany, UK, and the United States about our topic of conversation today entitled Gesundheit, Where in the World Can You Afford to Be Sick? It's both a thought-provoking and cheeky title, but one that concerns everyone. You can send us your feedback regarding healthcare and healthcare costs via our website at overhereoverthere.org or on Facebook, Twitter, or Instagram. I'm excited about our guests today because they offer a breadth of experience in the healthcare and media sectors. First, a warm welcome to my fellow podcaster and strategist, Claudia Koestler, senior editor of the Süddeutsche Zeitung in Munich. Claudia grew up in Bavaria and has an eclectic background, having lived in California, London, and Iceland, and in fact speaks Icelandic, as well as German, as we know, and has traveled widely. But she's a newspaper person through and through. Claudia, you named the title of this podcast. Do you have any memorable experiences of other healthcare systems while abroad?
In fact, I do. Hello to everyone, first of all. And when I was a kid, my parents traveled a lot and finally settled for a couple of years in Great Britain. And unfortunately, my father had a heart attack. That was in York, and he had to go to the York hospital. And my mother and me, we went along. And it was a truly appalling thing to experience as a kid that your father has such a horrible disease. But on the other hand, it is one of my most happy memories because we felt so in good hands at that hospital. And it was, of course, my first experience with the NHS. I had no clue whatsoever what an NHS is or a health system. But my father was in very good hands, and I remember that the doctor, he came and did not have a white suit on as they do in Germany. He came in a leisure jacket, sat on the bed and explained very calmly and very friendly how everything is going to be okay. And they even provided some rooms for us to stay with him. And in the end, everything went better and my father was okay and lived for a couple of happy years with us. So that was a very good experience how in a crisis you can be saved and made comfortable and things can work out. So it got me curious about other systems. And of course, being a German, I am here with my, I'm here in my country with my health system, but I kind of like to compare it to others. And when I recently got bitten by a cat and I got sepsis, I went to the hospital here and was treated for it and everything went okay and fine. But it kept me wondering because I just handed in a little card that stated that I have insurance and I never saw any bill. I never saw anything. I just got my treatment that was it. And that got me thinking, if I had another passport, would this be different? And I thought about American friends who told me, well, they have to go in and they're not handing in a card that says they have insurance. They hand in the credit card. And I was wondering, would I have been able to afford my treatment if I were an American citizen? Or would I have to haggle before I could finally get treatment? And this is something that is interesting and intriguing at the same time, and worrying also about the differences. And this is how the topic actually came about.
Thank you. Well, maybe our next guest could answer your questions on that one about the U.S. and all that. And our next guest is Mike Bellissimo. He lives outside of Boston, Massachusetts, whose career has taken him from Apple Computer, where we worked together in the same department for several glorious years. Right, Mike? After he continued on to Sun Microsystems, Yahoo, and Microsoft, then into the world of healthcare management and senior post at Humana and the renowned Cleveland Clinic in Ohio. And now, after all that, is doing a doctorate in business management at Case Western Reserve University in Cleveland, Ohio. What specifically, Mike, that doctorate at this time of your career? What's driven you to that?
Yeah, thanks, Dan. And it's great to catch up with you virtually here after all these years. I'm in the middle of my doctorate PhD at Case Western, and my focus is on healthcare sustainability. I'm a fellow at the Fowler Center, and the Fowler Center at Case Western promotes flourishing enterprises and sustainable enterprises across the globe. And the specific topic of healthcare sustainability is focused on, do the healthcare systems that we have today in the United States, as well as elsewhere in the world, are they sustainable? Meaning 50 years from now, will we have healthcare, right, the way we have it today, or is it currently set up such that it will fail us? It's not unlike thinking about global warming. Our discussions about global warming, is the current global warming situation sustainable? I think we would all agree, no, it's not. And in many ways, I make the same analogy between global warming and healthcare, because no longer is it a bordered need. We've learned through the pandemic that healthcare is borderless, and much like global warming is borderless. And so it's good that we're talking across the pond, if you will, about healthcare. I think it's an important topic for all of us to understand.
Great. Thanks very much. And it'll be interesting. We have upcoming podcasts that will shed more light on that for us. So thanks, Mike. We are also delighted to have Dr. Charlie Vivian, a former director in occupational health in the NHS, the National Health Service in the UK, and now a consultant in private practice and director of Icarus Health Solutions Limited. Charlie and most of his family caught COVID just a few months ago, and maybe you can just tell Charlie, how are you doing? How's the rest of your family? Your wife is a doctor as well. She caught COVID. How are you all doing?
Well, firstly, forgive me if I cough, because that's still ongoing every so often. At one level, I was going to say I think we were relatively lucky, because one of my daughters and my wife and I all caught it. And I think of all of us, my wife was worse affected and couldn't work for a couple of weeks and felt really a bit grim for about 4 or 5 weeks, I suppose. For me, it just felt like a head cold that wouldn't go away for about 4 weeks. And I suppose the thing is that actually, it's not actually that we were necessarily lucky. I think more correctly, we weren't unlucky, because of course, we now know that COVID is very clearly linked to your age. So the older you are, the more likely you are to get serious illness. You can still get serious illness when you're younger, but the chances of that are smaller. So I think I'd just say we were not unlucky by being relatively mildly affected.
Well, I wish you all the best. It sounds like you're recovering well, though.
Dan, I got back on the tennis court within 2 weeks.
Don't show off. Don't show off, man.
That's fine.
All right. Well, let's get into the discussion further. And I'll let Mike actually describe the U.S. system. He can do it probably far better than I can. But, as with this program, we're just talking about if you're in the U.S. And when my own experience is also, there is also a constant, as good as the U.S. system is, and it's the stellar, it's really top. I always felt, especially I'm from upstate New York and Rochester, which has fantastic hospitals, full confidence when you go there. If you're there and can get access to healthcare, you're going to be very well taken care of. But there's always this kind of hum of fear, whether when you're, meeting friends or at a dinner party, whatever, and you change jobs, are you covered? Are you covered? And that's the thing. You want to make sure that you can have access to that brilliant medical treatment that you can get. In the UK, the NHS has served its citizens since 1948, and is really the prized asset in the government's portfolio. You won't find many politicians daring speak against against the National Health Service here. Some do, but they're at the moment losing the battle. It's free at the point of use, which has been the mantra since 1948. And I can tell you from my own personal experience, have traveled in various countries, growing up in the U.S. and lived here half my life. I can't remember the last time I paid for anything, and I had some brilliant treatment. That does have some downsides, as we'll talk about as well. It's not all roses, but we'll get to that. In Germany, all citizens and legal residents are entitled to free medically necessary public health care, which is funded by Social Security contributions. However, citizens must still have either state or private health insurance covering at least hospital and outpatient medical treatment and pregnancy. So I've had a few experiences in Germany myself. And confirm this if you would, either, Claudia or Mike, if that we're talking here about in Germany is that for inpatient care, you're covered. But for outpatient, you've got to have some insurance. Is that correct?
What is actually, you have to help me with the term inpatient and outpatient.
Well, when you check into a hospital for an operation, and
okay.
they say here, medically necessary, that's when you are covered by the state.
Yes.
Right.
Yes, that's right.
Right. But when you go for a doctor's visit for some,
to a specialist, like.
Yeah. Or, if you're not feeling well, you got a strep throat or something like that. Are you covered? You have to.
Yes. Then you're covered too.
Yeah. But then you do have to get medical insurance. Is that correct? I'm just trying to, I'm thinking of our American audience that wants to relate to this.
I think you grabbed it very well. The German healthcare system is a dual public-private system that dates back to the 1880s, and thus making it the oldest in Europe, actually. And it works like this: if you are employed, you have to be insured, and you actually pay 14.6% of your gross salary into that insurance, and your employer pays the same, and that covers your health insurance. If you are not an employee, but you're an artist or self-employed, you can have private insurance, or at least you are obligated to have private insurance. And then, of course, you pay it completely yourself. But in any case, if you are an employee in Germany, you are always covered.
Always covered. Yes.
Mm-hmm.
Okay. Mike, can you do us a favor? And it's a complex task. I mean, we know that you can get great healthcare in the United States in, you say, various postcodes or zip codes, or whatever. But the actual system across the country, it's quite complex in a way. Could you just describe for our listeners just what the U.S. healthcare system, how it's made up, this is structure?
Yeah, absolutely, Dan. Absolutely. And first, Charlie, I'm glad that you and your family are well.
Thank you.
My daughter is a nurse practitioner in New York City, and her first 6 months of this year, she spent on the front lines at a major hospital in the city caring for pediatric COVID patients when the world was telling us that kids couldn't get COVID. Mm. My wife has spent the last few years in community health, and so she spends a lot of time as well with the community and their healthcare. And I, as you know, have spent the last decade in healthcare. So you could say that we're a family of healthcare people. And so we worry about it all the time. And I think you used the word fear earlier, Charlie, and Dan, and it's a good word because people are fearful right now. And this pandemic is an interesting experiment. It's an awful experiment, but it's one that we've never experienced in our lifetime. And it's laying bare the problems that we have with healthcare in the United States. It's as if, globally we had, I'll use this analogy. It's a terrible one. 1,000 Chernobyls all happening at once in different places. Healthcare inequities have been laid bare, especially as they exist in the United States. In the United States, we have a complex system, and I think you use that word, and I think it's a good word to use. I think it's different than the word complicated. It's actually not complicated. It's complex. And part of the reason why it's complex is because of how the United States itself is structured. We're 50, as I call it, loosely aligned states that are part of this democracy called the United States. And that's been our history for, 250 years. In the United States, you get healthcare in a variety of ways. As Claudia mentioned, you get healthcare through your employer, and that's considered private insurance. And you're not obligated to take it, but you're obligated to have some sort of health insurance if you have it through other means. You might be a veteran, and so therefore, if you're a veteran, you have healthcare through your veterans benefits. You might be a senior. In the United States, that's considered somebody over 65, and that means you're eligible for Medicare, which essentially is similar to the care that I think we heard Claudia and Charlie talk about in the UK and in Germany. You may be below a certain income threshold, in which case you're eligible for what's called Medicaid, and that's typically consumed by younger people who may be single parents raising children. It's not meant to be a long-term program like Medicare. It's meant to be a temporal one, meaning if you're between jobs or your income falls below a certain level. And lastly, I like to say healthcare is really only interesting in the last 5 years. What we did with Medicare and Medicaid was back in the 1940s. Everybody's heard about the Affordable Care Act, which Barack Obama pushed through while he was president, which basically requires all health insurers to provide a certain level of care coverage and all health providers to provide a certain level of care. Now, each state is allowed to kind of interpret that as it wishes. So I live in one of the best states in the country for healthcare, Massachusetts. We have something called Mass Care. We can enroll in that if we're not covered otherwise through our employer, or we're not old enough to qualify for Medicare. We can sign up for Mass Care. And Mass Care is similar to what we've heard described earlier. It provides basic coverage for basic care needs. So that's the complexity of healthcare in the United States today. One thing I'll add, and then I'll turn it back over to you, Dan, is that as a result of that complexity, it leaves a lot of people out. It leaves the poor out in many ways, in many cases. It leaves people who don't have access to any of those programs out. It points out some of the disparities in our country, as you pointed out, where people who are born in a certain zip code automatically start out at a deficit with a life expectancy that could be 10 or more years lower than people that are born in a zip code just across the freeway from them in the same city. So we start out in many cases with a deficit. And as a result of the pandemic, we've learned that by disinvesting in things like community care, public health care, we're really exposing a lot of our population, to terrible viruses like the pandemic is, and to a lack of good accessible care.
Yes, I mean, it's complex. And, when you think of the size of the United States and the states themselves in the beginning, the 50 states, and just the coverage and where the population densities are, and then all those individual states are, in a sense, are like little countries. That's why I think of them. And so they, the federal programs, as Mike mentioned, Medicare, Medicaid, the Affordable Care Act, Obamacare, and maybe a few others are things that help prop up and help make for some parts of the population make it affordable. But I guess at the moment, as I read, as of 2019, there's still 27 million who do not have health care coverage, and that 44% of them list the reason of because it's just not affordable for them at the moment. So not that they can access it, but can access it if they had the money, but they don't at the time. So anyway, we'll get on to that. But Charlie, let me just go back to the UK and the state versus private. People don't know. They hear about the NHS, but it's not all encompassing. There is a private sector, and I guess the ratio is 79% state versus 21% private. Can you just talk about that relationship? Because there's doctors who float back and forth.
Well, I think you made the comment earlier, Dan, which is absolutely right, which was that the NHS was set up on the basis of being free at the point of access to everyone. And that was sort of the guiding principle for its when it was founded. But interestingly, even from relatively early on, that wasn't maintained. So, for example, your vision, when you need spectacles and things, that was initially covered, but then stopped being covered. And likewise, prescriptions. So, the medication you get given is also not covered. You have to pay a prescription charge. So it's not completely free, but it is, generally free. You don't pay to see the doctor. You don't pay for your surgery or physiotherapy or whatever. I think when I was a GP, gosh, that's 20 years ago now. Every so often you would have a patient come in who'd say, well, and you'd be saying to them, well, you can't really have that. I can't refer you for that particular investigation or treatment or whatever. And they would say, well, I pay my taxes. So there was a transactional element to it, but it was that the patient had paid their taxes rather than was paying directly for the treatment or directly, into a health insurance fund. So I think in the UK, we kind of have our heads around that, what that looks like. But I think increasingly people are often moving over into the private sector, primarily because of the pressures on the NHS in terms of the wait. And I'll talk a little bit about that later, the challenges of waiting lists. But interestingly, it's not only individuals who are doing that, but actually many organisations now will pay for some healthcare. It's very common for larger organisations to have employee assistance programs, which are the sort of the counselling and things like that, and will often have access to physiotherapy as well. And some will go even further and say, well, look, the cost to us of having this person off sick because they need their knee operation, for example, is much higher than the cost of the knee operation itself. So we'll go ahead and pay for that. So we are seeing that sort of gradual move over into more private care.
Is that a capacity issue? They just can't. I'm one of them. I'll just say I had a hernia, and I was. They have farmed out hernia operations to the private sector, and that's how I got treated, even though it didn't cost me anything.
Well, you're right. A lot of routine surgery is now done by private hospitals, by private care instead. But I think there are various initiatives to try and reduce the waiting list, but I think there is a fundamental reason for that, which again I'll touch on later.
Okay, Mike, can I just come back to you, and then I'll move on to Claudia about it's almost the same question, but I think it just needs to be further clarified at the individual level. When an individual goes to the doctor, I just want to, have you describe maybe their thought process of what they're confronting as far as the system goes, because there's a lot of terminology involved in what one, you pay it outright in some cases. But then if you have some kind of insurance, there's things like premiums, which you have to pay for that insurance, or co-pays, deductibles, co-insurance, and all of that. But it's kind of daunting, isn't it?
It can be. I think, at the end of the day, healthcare has been attempted to be consumerized, right? People have said, well, healthcare is like everything else, right? People consume it and they look for the best quality, the lowest cost, and the greatest convenience. And that may be true, for things that are not urgent. But for the most part, like we just heard from Charlie and from Claudia earlier, people go seek care when they have an issue, when they're sick, when something's wrong, when something's not feeling well. And so in that moment, they're vulnerable. And in that moment, really all they want is to consult with somebody that can help them get better with whatever it turns out being. And thankfully, if it's not chronic, it's something that could be treated with, with outpatient care or with medication or both. Or if it is something that's chronic, it can be treated in one of our hospitals. When somebody shows up at a doctor, if they're insured through an employer, they show up with employer-based insurance, and that comes from one of the insurance companies in the country, and it entitles them to a certain amount of care. There's usually a deductible and a copay, and what the copay represents is some nominal amount that you pay at the time you seek care, and we're talking about less than $100 usually, but deductibles can be as high as $10,000 before your plan reimburses you. And there's been this novel concept of high deductible health plans lately, which basically reduce the premiums to employers and to employees. But as you know, with all things, you kind of get what you pay for. So a high deductible plan essentially means that, I think Charlie used the description earlier of a knee, replacement. If the cost of care is less than the cost of insurance, well, you kind of have a problem. It's sort of like when you take your car in and the mechanic says it's going to cost $2,000 to replace the brakes and your deductible is $2,000. You're like, what am I going to do? And so that's the issue with healthcare in the United States when it comes to private insurance. When it comes to public insurance, it's a little bit clearer because the United States Centers for Medicaid and Medicare Services, CMS, basically sets the price. And they basically tell doctors, you can't charge more than X amount for this particular care because we have to pay for it. And so it's a little bit cleaner, a little bit clearer, a little bit more like what Claudia described in Germany when you show up to the doctor, if you have one of the federally funded programs or one of the state programs. We have a program called Mass Care here in the United States. They're affiliated with Blue Cross Blue Shield. I have that care, for example. All of my well care is covered, zero deductible, zero copay. My annual physicals, all of my annual inoculations, basic medication. I take a Crestor, statin. That's all covered free of charge, basically because the insurance company and the healthcare providers have negotiated that together. So those are just some examples. And then there are people who show up without any insurance at all, or without any healthcare coverage at all. They don't get turned away. You hear stories about this.
Who pays for that? And who pays? Yeah.
Well. See, that's so. Private insurance pays for it. The general public pays for it. So at the end of the day, the reason why private insurance premiums are so high are to offset the cost of care to people who can't pay, as well as to people who are covered by a federal program, which essentially, sets the price at about 10% of what, the market rate might be for, a particular procedure. So we all pay. And back to my point earlier, we all pay when it comes to not everybody having good health care. We all pay when people are chronically ill and wait till the last minute to get care. And we're learning that we all pay across the world when somebody gets sick in China and a month later, people are sick all over the globe. And so I think we're learning a lot about what's wrong with healthcare in general and healthcare in the United States.
And of course, the costs cannot be easily distributed across 50 states, each with its own healthcare system. So whereas here in the UK, the National Health Service has purchasing power and greater economies of scale by spreading costs across a population of about 67 million people. Unless you're a U.S. state or a city that has a large population like San Francisco, New York, or Boston, Americans will be paying more, right? To the pharmaceutical companies, the hospitals, the other healthcare suppliers. That doesn't seem equitable or honoring one's human right to healthcare.
The crux of the issue, I believe, is healthcare a right or a privilege, right? Is healthcare a basic human right? Is the basic human right healthy water, clean water, access to healthy food? I hate to be so blunt, but is healthcare a right or a privilege? I think we would all like to agree, and hopefully we would agree that healthcare is a right. It's a basic human right. Access to care is a basic human right. And in many places, it's treated as a privilege. In many places, it's treated as a for-profit industry. And, we should argue that, right? Because you use the example of pharmaceutical companies in the UK having purchasing power. Well, the population of the United States is 10 times the population of the UK. Certainly, there's a lot of purchasing power here. And yet, why can European pharmaceutical companies charge 10 times more for the same medication in the United States than they can in the European Union? It's an interesting question, right? And so, because we've essentially commercialized healthcare, we've made healthcare a for-profit industry. And the question we should ask ourselves is should it be? Should healthcare be a for-profit industry, or should basic healthcare, and basic healthcare meaning all the things that we've heard this morning on this podcast, access to good quality care when I need it, should that be a right or a privilege? I think that's an interesting question to ask, and I'll be blunt and say it's a right. It should be a right, and it shouldn't be a for-profit to provide basic care to humans across the globe. But it is.
So, Mike, you think the U.S. should make healthcare a human right and abide by the UN definition as mentioned at the top of the podcast?
Not think. I mean, you can't have been raised ethically and morally anywhere you were raised in the world without wondering, why doesn't everybody have the same rights I do, right? Why doesn't everybody have the same access to the things I just described? It's unethical. And that's really the problem that we need to solve. And I do believe it's a cross-border problem. And again, I'll continue to bring up the pandemic because we shouldn't ignore it. I mean, this pandemic will be over, but there will be future pandemics or future issues like this. And we will learn as a human race that healthcare is something we're all inextricably linked together with, as we are with things like global warming. Again, because we can't avoid when something happens in one part of the world it affecting another part of the world anymore. We just cannot avoid that. And so we're going to have to figure out a way to make this work. Pharmaceutical companies are going to figure out a way, going to have to figure out a way to make enough money to be in business without charging the US 10 times more than they can charge the EU in order to be profitable. That just is not sustainable. That model is not sustainable. We've learned from Americans who cross into Canada, well, until the pandemic, cross into Canada to buy medication. That's just crazy. Medication, by the way, made by U.S. pharmaceutical companies and manufactured in Puerto Rico. It's crazy. It's a crazy model.
I'm your host, Dan Harris, and I'm speaking with Claudia Koestler, senior editor of the Süddeutsche Zeitung in Munich, Mike Bellissimo, a senior executive in healthcare and high technology in Boston, Massachusetts, and Dr. Charlie Vivian, director of Icarus Health Solutions and a former director in the NHS. We're discussing the topic, Gesundheit. Where in the world can you afford to be sick? Claudia, in light of the pandemic in Germany, is the healthcare sector getting the help it needs?
I think so, it does, yes. But of course, there are also some issues, and issues that have been around for a longer time, and issues that are maybe now overshadowed by the pandemic. The good news about the whole thing with COVID is that we all seem to be able to get a vaccine and at no extra cost. So that is a good prospect for our country at the moment. But underlying, of course, are some issues with the health insurance sector. And that is that we have those both sides, private and public insurance way. And the public one does not cover consultations with private doctors, private rooms in hospitals, or alternative or complementary treatments. So basically, if you are one of the millions that have a public insurance, you have a tendency to feel a bit left out of the best treatment possible. And then you have the possibility to top your insurance up privately to match or equal the private insurance levels. But then, of course, you're back at the issue. You have to be able to afford that. And this is a gap, actually, that people feel a bit second class if they have the regular insurance, and they are a bit jealous of those who can actually afford being a private patient. And there is always the rumor that they are not only treated with better medication, but they are first in line when it comes to operations or vaccines or whatever. So this is not yet tackled at all. And I have the impression that it divides us further here as a society. So, of course, after we are done with the pandemic, this is something we have to address. Is there a way to keep a balance here and to provide the best possible care for everyone? And how do we finance that?
That's what I was going to ask you about balance. That was my impression of Germany. That was a question. Do they have the balance right? I mean, their percentage between state and private is almost same as the UK. About 77% is state and 23% private. But you know, when I've traveled to Germany, and talked to friends, they tell me what you were recounting there, and about topping up, making sure that you're at the height, almost
right.
at the first in line.
Right.
And given what Mike was saying earlier about, access to care and a human right, it sounds like, yes, they do in Germany, but it's a little bit looser. It's not as embraced, given that what you just described, would you say?
Yeah, that's quite right.
Charlie, we clapped for the NHS during the pandemic. We're not clapping anymore, but obviously we're very concerned. That was a bit of a program which helped boost morale early in the pandemic. Are we getting support? I'm based here in the UK along with you. What kind of support is needed? Are we getting the support that you think we require?
I think it's really difficult, actually, because one of the challenges in the NHS has been the cry of underfunding. I'm a great fan of the iron triangle of quality, time, and cost. And you can't you can't change one without it having an impact on the other two. So, for example, if you want the best quality medical system, you either need more time to deliver that, or you need more money to deliver that. You can't break that triangle. And of course, the challenge is which many will argue that the NHS has been chronically underfunded for many, many years. But if we still want to deliver high quality care, then the only thing we can do is sacrifice the waits that people have to wait for that. And so that's one of the challenges I think we face generally in healthcare delivery within the UK is, people just have to wait a long time to receive the care that otherwise they would be able to get much more quickly. I think within the context of the pandemic, the additional challenges that, the hospitals are normally really busy over the winter months. I mean, really, really busy. There's nothing unusual about that. And I think the challenge is that what the pandemic is doing is it's creating a new large number of people who are really quite poorly, who need to go into hospital, and there simply isn't enough resourcing for that. And I want to be really clear what I mean by that. It's not so much that there aren't the buildings, because of course what the government did was it built these Nightingale hospitals, which were large, built in warehouses and things like that. So there were beds and there were some ingenious ventilators and things were built, absolutely fantastic. The challenge is actually the staffing issues. So we just haven't got enough staff to suddenly see a large swell. And I'm hearing more and more stories of healthcare workers who are really on their last legs, who are completely demoralised by by just how hard they are working to try and actually provide support to the UK population. And of course, with all the the sort of the conspiracy theories and anti-vaccine type thing comments, I think a lot of healthcare workers are really struggling with that.
And Mike, we hear that certain states are really struggling. Is it just the vaccine that's going to be the answer, or what else can be done to help out these various states and their healthcare systems?
Well, what's interesting to me is how we are responding to the pandemic and what will happen after it's over. Obviously, it's unacceptable that nurses and doctors didn't have sufficient PPE, and that was true. We were making masks and booties and head coverings for our daughter and sending them to her hospital. Believe it or not, a major hospital in New York City, we were doing that. And part of the reason for that was just simply they were unprepared, and not through any fault of their own. No one could have been prepared for this pandemic. Each of them were procuring what they thought they needed for a usual normal situation, maybe with a little bit of a bump for crisis. You mentioned San Francisco. I work with some hospital systems there. They're always prepared for an earthquake. But what they know is, well, if we have an earthquake in San Francisco, we have LA that we can rely on, and we have Sacramento. But this pandemic has basically laid bare the fact that all of those locations are now inextricably linked. What I learned from my research was that hospitals that collaborated and cooperated with each other, that shared things they would never share before, like their admit rates, like how many patients they had in the ICU, like how many masks, gloves, booties, head coverings they had. They would never share that information with each other before, just out of sheer competition. They then ended up sharing all of that, realizing that they were all responsible for the care in the community. And these are not small cities. I'm talking about Philadelphia, Cleveland, San Francisco, which learned a lot from the AIDS crisis on how to do this. And so the big question for us all will be, what did we learn? And what will we do better when this is over, so that when the next pandemic happens, we'll be better prepared for that? So I liked what Charlie said about quality, cost, and time, because we've all sort of become used to the fact that we have a right to have something when we want it and how we want it. I mean, as a human race, we've become that way over the last few decades. And one of the challenges with healthcare is that really isn't sustainable. Most people who need care, it isn't an urgent need. For most people, what they need is something that can wait a little while. And, are we willing to wait a little while? Are we willing to give up a little bit of convenience in order to get treated when we need to, so that somebody else who has a chronic issue can be treated ahead of us? Am I willing to wait for the vaccine until the fall in order for everybody else that really should have it before me gets it? I am. Of course, I should be. And that's the right moral and ethical thing to do. But we're going to have to learn how to operate differently if we want to change things.
We're coming to the end here. Would you keep your own system or adopt a certain policy or another idea that would help your system where you are? Can I start with Claudia?
Very good question. And I am thinking about the possibility if I could get the NHS here in Germany, but I'm actually unsure if I would. As much as I love the NHS and as much as I admire it, and it deserves all that was going on with the clapping and bowing to it, I wonder if it is good that the British people do not see it in their paycheck every month how much they have to pay for it or how much it actually needs. The sums that you hear are way too much to get into your brain once in a year or whenever you listen to that. But when I look at my paycheck, I see that I'm paying 300, 400 euros a month. And of course, I'm not that often at a GP, so I'm not using it, but I'm contributing to my system. So I kind of am reminded about on the value of our healthcare system. And that might be something good. On the other hand, I like the idea that it is free for everyone, because I think truly this is necessary. We have to get everyone access to the best possible treatment when necessary. But it is a question of valuing it. And we have to tackle that, I think, globally and not within our little communities and little countries. This is something after the pandemic we should discuss on a global scheme, how we can support each other with knowledge, with healthcare systems that might be something to export partly, or if it's just informations. I think we should stop looking at our doorstep and looking much more into the world and how we can contribute to something good and to get something good from anywhere else.
Charlie, what would work well if you brought it home to the UK?
Do you know what? I'm going to go off-piste because what we now know very clearly is that social determinants of health account for something like 75% of the risk to life. We have really, really strong evidence about that. The wonderful Norton Hadler from the United States and his book, The Last Well Person. We've got Richard Wilkinson and Kate Pickett, who are at the spirit level, looking at the evidence for that. And then the work done by Michael Marmot, again, here in the UK, where he looked at the health gap. So, inequality in a society we now know is a major, major risk factor for mortality. And therefore, reducing the amount of inequality within a society has far more benefit to health than whatever health system you are looking at, you're looking to introduce. I think it's absolutely fascinating, for example, that the life expectancy in the United States is actually pretty similar to the life expectancy in Cuba, which is one of those things where you just go, well, that's extraordinary. And I think at the moment, almost across the world, what we're focused on is wealth. We're focused on the GDP of any country. But I'd like to suggest that actually happiness and life expectancy are also very good indicators for whether or not you are actually living in a good country. And what's interesting is that there's a measure called the Human Development Index, which grasps exactly that. And what's fascinating is that the best countries in the world are the Nordic countries. So I don't know an awful lot about the Nordic health system, but I am quite sure that we should all be looking at what the Nordic countries are doing at a political and economic and social level, because they're getting it right, and that would be where I would want to go and have a look and understand how they do things.
Yes, I mean Denmark or Finland are always number one or number two. It seems like. Mike, you have the last word. What would you like to see if you could look and bring something back to the United States that would help? Anything that strikes you?
Yeah, I'll build off of what Claudia and Charlie both said. It's funny how we're all looking north. So looking north of the United States is Canada, and up until about 1980. The Canadian system and the American system were very similar in terms of access to care. things changed pretty drastically about 1980. Canada, as you know, went to more of a national healthcare system, more like what we've heard exists in Europe today. And the United States went to HMOs and, more emphasis on private care and private insurance. And in the 40 years since that happened, the cost of care in the United States has gone up exponentially. I think we are now spending somewhere close to 20% of GDP on healthcare in the United States. 50 of the Fortune 500 companies are healthcare companies. Our life expectancy, I think, is stuck at about 78 years now. And in other countries, as Charlie mentioned, it's continued to improve. So clearly something is wrong. And it's interesting to look north and to see what are some of the things that Canada got right that we could try to emulate, all the while understanding that, again, we're talking about a country of 350 million people with demographics that are very different than the Canadian country, than Canada. And so understanding what worked, what can be copied. And then lastly, what Claudia mentioned earlier, that is, what can we learn from each other, right? We're learning a lot about healthcare systems in other countries as a result of the pandemic. And so how can we learn from each other about what works elsewhere that we could try here? Maybe that's a last word from me, which is we need to stop politicizing healthcare. I think the fact that healthcare is politicized across the world, not just in the United States, is really what's been its downfall. It needs to stop being politicized. Healthcare is not a political issue. It's a basic human right. And that when we start there, we start the conversation there, then it's a very different kind of conversation.
Great. It's a great way to end. Great, hopeful way to end. So thank you very much to our guests, Claudia Koestler, Mike Bellissimo, and Dr. Charlie Vivian. Before we close, we'd like to remind our listeners that they can subscribe to our podcast by the button below, which can be found on most major podcast platforms. You can also follow us on Twitter, Facebook, and Instagram, and today's podcast show notes should be on our website soon on overhereoverthere.org. We very much appreciate your support. If you have any polite, insightful, constructive comments, we welcome them in any language. So thank you very much for listening, and check out our website for the next unmissable podcasts. And until then, thank you for listening to Over Here, Over There.